One day I'll get it right. Okay. So I probably don't really need to go through the background in that we heard most of this from Graham this morning, and I'm trying to get it to progress. There we go. Well, that could even keep me awake, couldn't it? All right. Okay. So we heard all that already. So the next thing is really that given that we know smoking is bad in very specific ways, I think it's probably fair to say we've agreed that optimal cancer care, and people have already thought this, optimal cancer care includes all measures that are known to improve long-term cancer outcomes. And so really, if we want to give people the full toolbox of cancer care, then quitting support needs to be part of that if they're a smoker or a recent quitter. So we know a little bit about what's happening in Australia for cancer patients, but not much. If you were in an earlier session, you would have heard a presentation from Emma Sherwood telling us a little bit more. But we do know that somewhere between 10 and 20%, perhaps more, of patients who attend oncology outpatient clinics are smokers in Australia. We heard in a fair bit of detail from Graham this morning that in America we know that oncologists are pretty good at asking about tobacco use and not so good at actively treating or referring for tobacco cessation support. And so that's a pretty big leap for a cancer patient to make, to be successful in cessation with pretty limited support. Now, Australia has a pretty high reputation in the tobacco control world for doing very well, and so we might have reason to believe that we're doing a bit better than the American oncologists given the environment that we're all living in. But there's very little thus far that we know about that, so it's important to answer that question. Are we doing better in Australia with smoking cessation care for cancer patients? So the aims of this particular study were to identify what the prevalence was of Australian oncologists' provision of smoking cessation care, to look at what the factors underlying that might be, and I thought because I'm a behavioural scientist we use the Colm-B model to look at those things, and don't worry, I'll tell you what it is, and also to, on the expectation that there's going to be some need for training, to see what oncologists in Australia would like in terms of training and support. So this study involved 2 surveys, one of medical oncologists via MOGA and one of radiation oncologists via TROG. So you can see there that there are about 450 members of MOGA and 230 radiation oncologists within TROG. Both of those groups got a hard copy mailed survey because, believe it or not, in these times they're actually more likely to do it on hard copy than electronically. The MOGA people got 2 email reminders with a link to do it electronically if they wanted to do it that way. The TROG, for whatever reason, only needed 1. And at the end, we got just over 40% of each of those groups, so 189 of the MOs and 106 of the ROs. So this is just a bit of a flavour of the questions that we were asking them. They're taken pretty much from Graham Warren's surveys that he did overseas, so thank you for sharing. So you can see there, this is the kind of questions that they were answering about, whether they asked patients if they smoked or used tobacco products, and they could say how often that happened. So we asked them each of those steps through that process of asking, advising, referring, what they were discussing, and whether they were doing that kind of thing themselves or getting other people to do it. There were also a number of opinion items that we put to them. Again, a lot of those come from Graham Warren's work, where they were asked how much they agree with a series of statements like tobacco cessation should be a standard part of care for cancer patients, and that each member of the oncology team should play a role in it, through to things like you can see at the bottom there about whether they specifically had some need for a better understanding of things like pharmacotherapies, given that the evidence tells us that that's a really important part of helping this particular group to quit. So what were the results? And because I'm a researcher, I get really excited, like it's fireworks, when you actually have data to play with. So this is just a bit of a description of what the oncologist sample looked like. You can see that we had a fair representation from across the states. We had the the majority of the participants working in metropolitan public hospitals, but also regional public hospitals, and we had some from metropolitan private hospitals and even a few from regional private hospitals. So we're getting a fair spread of workplaces there. In terms of years worked, the majority, or probably around half, were people who had more than 10 years experience, but you can see from that little asterisk, we had a larger proportion of our medical oncologists being within 1 year of their professional qualification. So our medical oncologists and our radiation oncologist sample were slightly different in terms of experience. And also you can see at the bottom there, the most common sites that our sample were treating were breast, thoracic and gastrointestinal cancers, but also a number of others. And those other little asterisks are telling you that the medical versus radiation oncologists saw slightly different types of patients, as you might expect. So then on to what did they tell us about what they were doing. So this figure is the proportion of both groups who reported that they always or most of the time do each of these things in the very initial consult, the first time that they see patients. And that's important because we know we want to give patients the best opportunity possible to quit before treatment starts. So just as has been found in America, over 90% of our clinicians say, yes, we ask about this, and close to 90% say, yes, they assess the amount of tobacco. It's slightly less rosy around the proportion who are advising people to quit. So that's around the 60 to 70% mark. And then we're falling below 60% when we get to things about, do they ask if there's a plan to quit? And then we fall off a cliff with things like discussing pharmacotherapies, whether they choose to actively treat in terms of tobacco cessation. A little bit better than that, just under 20% for referring to some sort of program. You can see there less than 10% will provide a brochure, which seems like a fairly straightforward thing to do, so perhaps they don't have any. And then a bit of a difference there, but still less than 20% who would do something like referring to a tobacco cessation specialist. So the pattern is similar to what you see overseas. They will ask and assess, but that really important part of the process about helping and supporting people to quit is not something that's really going well in terms of Australian oncologists in general. So then we wanted to ask about the consultations following that initial one, given that we know that smoking is really a chronic relapsing condition and it's not a one-off conversation that's going to get you over the line. So here you can see that a much lower proportion of oncologists say that they ask about smoking in those subsequent consultations. There's around half are either advising people to quit at that point or reinforcing the importance of it, so they're not totally off the case, but there's a very low proportion, less than 10%, who will do something around active treatment or referral at one of those subsequent consultations. And there was a radiation oncologist who did actively treat, so it looks like zero there, but it wasn't, so don't feel bad if you're a radiation oncologist. Okay. So now we wanted to get a bit of a sense of what was happening in terms of whether they were referring or talking to all types of cancer patients or were making decisions about who should or shouldn't quit. And there's a little bit of rubberiness that I would now tidy up if I had my time again around the question, which was who would you regularly provide tobacco cessation assistance to? And I think what that means is it's a bit hard to interpret the absolute proportions here. So the thing that's of interest is the relative issues. So in terms of which relative cancers, relative types of patient groups are going to be advised or have smoking discussed with them. If it's tobacco-related cancer, it's more likely than a non-tobacco related cancer. In the case of whether it's curable or whether you've just do it across the board for all patients, including metastatic ones, you can see there's a bit of a difference there between the medical and radiation oncologists, such that the medical oncologists were much more likely to say, yes, I do this with all of my patients regardless of stage or circumstance, whereas the radiation oncologists were more down the line of saying we focus on the curable patients if we're going to talk about smoking. So that was one interesting point there. And then if we looked at what oncologists say is their preferred approach to support, it looks a bit like the sad pie graph that Graham showed us this morning, that while on the left you can see they're quite happy with the idea of having a trained person at their own institution do this, they're still more than half of them are happy for a GP to do it. Less than half think they want to refer to someone who is outside their organisation, like Quitline, and Quitline was one of the examples that we gave, so there's a little bit of concern around Quitline, I think, but absolutely not did they want to do it themselves. So that's a pretty clear message that radiation and medical oncologists in Australia are much like those overseas. They don't really see it as something that they want to engage with. Also, in terms of preferred timing of support, we thought it was important to find out whether that sense that it needed to be early in the process, whether that was strongly there. And you can see right over on the right-hand side at the bottom of the graph there that there's 25 to 30% were saying their preference was that it was at the second consult. So people are already moving down the path, and we think that that has something to do with the number of things that have to be dealt with in the very first consult. So that tells us something about the way that we want to approach interventions if we want to change this. And you can see that there's also a fair proportion there, around 50%, who were saying this should happen after treatment. So people would miss that opportunity for reducing side effects and so forth of treatment. And the referrer choice category there just meant that they weren't concerned about when it happened. They were happy to leave it up to the person they referred to decide where in the process the support should get delivered. So then I wanted to just look a little bit at the attitudinal items about what's driving these sorts of behaviours. And the COM-B model is pretty simple. It just divides behaviour into capability, motivation and opportunity being the factors that are interrelated but together drive behaviour. And some of you might have seen this model as part of the behaviour change wheel, and it's the central green part that's just saying for each of us, there are those three factors of capability, motivation and opportunity that are going to drive our behaviour. So all I've done, don't worry, I'm not going to deep dive into psychology and bore you further, I'm just going to divide the attitudinal items up into those three categories of the COM-B model. So the top one, the red one, capability, these are the items that were around looking at whether oncologists felt that they had the capability to provide cessation support. The darker red colour is strongly agree, and the lighter red is just agree. And I did a bit of playing around with the way this is presented so that not all items were kind of positively framed, but I'm presenting them that way for simplicity. So you can see that less than 20% agreed with any one of those items that's effectively saying, yes, I have the capability to provide cessation support. So that's things like knowing about pharmacotherapies, having sufficient experience, feeling that you will be able to get patients to quit. And the O is for oncologists. So the item was oncologists don't need more training, and they're saying that they agree with that. And also whether or not they felt they personally had adequate training. So what that part of the message is telling us is that they feel pretty low on capability. Then if we look at the bottom at opportunity, about things like having resources, having a perception that patients will resist being provided support to quit, and whether or not they have time. Again, we're looking at less than 20% are saying, yes, I've got sufficient opportunity to make this change. So we're not doing very well in terms of driving behaviour if both capability and opportunity are that low, but the bright side is the motivation. So you can see the lower of those three yellow bars about believes that it should be a standard part of care, so they are motivated from that perspective. They do believe that it impacts patients' outcomes, and they don't see it as a waste of time. The bit where there's a bit of a quibble is around that perception that it might impact treatment. So while they're strongly motivated from the perception of it being a worthy thing to do, there's a bit of a concern about how that might impact on patients around things like quality of life and coping during the treatment process. So that's an important additional piece of information for us to bear in mind when we're plotting our way forward. So again, just looking at, assuming that some training is both useful and needed, preferences for training were just over half are agreeing that basic skills are appropriate for oncologists. So while they don't want to do it themselves, they do believe it's useful for them to have a better understanding than they currently do. 42% thought that that it might be useful to have advanced or specialist skills. So that's for an oncologist. So perhaps they don't have time to use them, but they feel there's some value in having them. Just under a third said that the form of training that they wanted was online. 25% said that their preference would be for having some very specific professional guidelines. 22% wanted face-to-face training at meetings or conferences, and just under 20% wanted face-to-face training at their own institution. And so what that says to me is that just having one training mode like developing an online course is not really going to be what we need. We need a bit of a fruit salad of different ranges and types and levels and modes of training. So there are just a few additional points that came out from the open-ended questions, and I think I just want to say thank you, just in case there are any people in the room who took the time to fill out the survey and put in those kind of additional things which were really helpful to flesh out what we were finding. So there were quite a few comments suggesting that oncologists don't see smoking cessation support as being part of treatment. So saying things like, it's difficult to meet the demands of providing information on cancer treatments themselves, let alone time dedicated to smoking cessation. So that idea that it's not part of treatment. A view that their role is an advisory one, particularly that idea that I encourage, I support, I don't push, and I don't want to manage it myself. A perception that it's an overload for patients, that they've got too much information to process, and that they're actively opposed to the idea of doing it during treatment. But our patient surveys tell us that's perhaps not so. And also a view that perhaps for some patients they're trying to balance the idea of benefit versus quality of life. And one said in relation to incurable patients, I don't believe they necessarily need to cease smoking, and I think it impacts negatively on their quality of life. There isn't any data that says that that's true, but that's a perception that's out there. So where do we go from here? I think what this particular study tells us that there is general support with a few little caveats to the idea of delivering smoking cessation care in the oncology setting, but to move forward we're going to really need some practical models and pathways of care which bear in mind those things like the need to have it perceived as being integrated and part of care. We need to move to support, which is beyond just asking and advising, recognise that it's a chronic relapsing kind of condition and that oncologists just do not have a lot of time to commit to it themselves. So that means we need accessible, trained other people to deliver that support in whatever form that takes. And we do need a bit more data. Being a researcher, of course, we need more data on things like patient perspectives, what general practitioners perceive their role and their skills and abilities are in this process, getting a bit more information around quitline acceptability and effectiveness for this particular sample of people or population, and also understanding a bit more clearly what the role of continued smoking is in advanced disease. So that's very specific to radiation oncologists and medical oncologists' decision making. And of course we need strategies to address things around capability and opportunity so that they can actually deliver the behaviour in as much as is humanly possible. And I'd just like to end by acknowledging funders and supporters and of course the survey participants. So thank you everyone.